Thanks for having me talk today. So I know Ash really wants enough time for his talk, and I should really get moving on these slides. We'll go ahead and get started. So I was able to work on a few projects during my research years over in the biomedical engineering group, but one of the aspects of medicine that we wanted to focus on was trying to assess myocardial tissue stiffness. We all know when you look at an echo or an MRI, you can see wall motion abnormalities, but you never know exactly what's wrong with the underlying tissue. We often talk about diastolic dysfunction or impaired diastolic filling. This can be due to the stiff heart kind of syndromes we talk about, or it could just be volume abnormalities. Again, we can use a lot of surrogate markers, but it's always hard to truly assess exactly what's wrong with underlying myocardium. Current clinical MRI gives us the opportunity to do delayed hyper-enhancement imaging, through which we can identify areas of infarction and fibrosis. And those areas may certainly be stiff, but the areas that don't have that increased gadolinium uptake, we still can't assess for stiffness. And so I think the ability to identify areas of the heart that are stiffer than normal tissue could impact our differential diagnoses for patients, and also inform us as far as what therapeutic targets or pathways we would choose for particular patients. So to study this problem, I was able to work in Greg Trahey's lab here in biomedical engineering, and they've developed an ultrasound method called acoustic radiation force impulse imaging. And what this represents is basically you take, in very basic terms, very kind of high energy ultrasound pulses, target it to tissue, and then the pulses strike tissue. And then we can actually measure the axial displacement that occurs in that tissue in response to these pulses. And based on that displacement, you get a sense of how stiff tissue is. Something that's soft and compliant would be displaced further than something that's stiff and not compliant, which really wouldn't be moved much by these ultrasound pulses. Now, this is a fairly novel and now non-invasive way to assess tissue stiffness. It's been developed in the last 10 to 15 years in Greg Trahey's lab, and they've actually studied other organs, the breast, liver, kidney, and prostate, to name a few, where they've effectively shown that non-invasively they can differentiate normal from abnormal tissue just based on tissue response to these ultrasound pulses. Now, in the heart, they've more recently shown, working with some of our EP colleagues, that they can differentiate areas of the heart that have been stiffened after ablation versus those that have not been affected by ablation. Now, one of the reasons that cardiac RF to date has not been fully examined is that it's much more complicated than these other organs, for obvious reasons that it has intrinsic motion. So we're trying to measure axial displacements in the range of microns when a heart can move whole centimeters. So it's required a lot of technical advance as far as software processing and actual algorithms to be able to filter out intrinsic cardiac motion and measure true displacements. Now, if we are able to accurately assess tissue stiffness using these methods, I'm sure all of us in this room could think of many potential applications. Some could be in the acute MI setting. Is an area of wall motion abnormality truly infarcted, or is it just ischemic? We often follow patients in the echo lab for chemotherapy, and by the time their EF has dropped, often that's too late, and they've already suffered some tissue damage. This could be an optimal way to assess tissue to see if there's been underlying damage before an overall EF drop. And of course, infiltrative cardiomyopathies would be another great opportunity to use a non-invasive assessment of tissue stiffness. So we thought we initially would try to demonstrate feasibility of these methods in animal models. We actually created a longitudinal study in pigs and did some other studies in canines. We mostly focused on pigs, and that's what I'll be talking about for the most part. For these studies, we did non-invasive assessment using transthoracic echo, where the echo probe would just deliver these ultrasonic pulses through the skin. And then we also did invasive assessment using ICE, where intravascular echo was used to assess tissue stiffness. And before I move on too much farther, I just want to give you a sense of the kind of graphs and data we'll be looking at. So on the left, I know it probably doesn't project very well, but this is basically M-mode data from ultrasound. On the y-axis is axial distance from the probe. So this is the skin surface, and this is 8 centimeters away from the probe. And on the x-axis is time across our total acquisition. So basically, this is M-mode down the center line of the probe, and it's just shooting targeted tissues. And the area within the yellow lines is what we've targeted as myocardium. Now, our results are displayed as seen on the right here. On the x-axis, again, we have distance from the probe, or sorry, on the y-axis, and on the x-axis is time and acquisition. And these colors represent actual displacement induced by the ultrasound pulses. So areas that are red are induced further and would represent softer tissues, whereas areas that are blue are not displaced much, and these are stiffer, harder tissues. So you can see nice cyclic variations through a cardiac cycle here. So as far as the general outline of how we approach the animal studies, we in total studied 6 pigs, and we performed these for the most part over at Synacor here in RTP. We performed RFE analyses at baseline using both transthoracic and ICE methods in healthy pigs, and subsequently they performed selective embolizations into the LAD with some foam substance that they use over there to create what we thought would be localized infarcts, so we could assess over a longitudinal assessment what happens to infarct as far as tissue stiffness, and what happens to the rest of the ventricle as you have an infarction form. Now, we performed these over the next 2 to 3 months. Finally, we concluded the studies by finishing our last animal experiment here at Duke. At that time, we actually did some work with CARTO and made an electroanatomical map of infarct. And additionally, we excised the heart and performed whole heart MRI to identify by gadolinium where actual infarct was. And just to kind of prove that we actually did some work during these 2 years, we have some pictures documenting that this is me trying to ultrasound this big pig here. They had a table there where they had a cutout in the bottom, and I could access whatever part of the skin I needed to get the pictures. You'll see that this is our ultrasound machine over here. It's not a clinical scanner we're used to. We actually used a Verisonics research scanner for a couple of reasons, mostly because it allowed for very fast data acquisition and processing, and also had a very stable power supply that was probably better than the clinical scanners we could use, and allowed for a very easy kind of software manipulation and programming for the pulses we needed. This is David Bradway here in the back. He's been my partner through these 2 years, and I couldn't have done any of this research without him. He's the engineering side of all these studies. He did all the sequence programming, developed the kind of RFE protocols, and set everything up for us to be successful. This is a picture of our ICE setup over at Synacor. This is a clinical scanner that we use that most people are more familiar with looking at. And then this is the table where the pig would be cathed, or we'd access the IJ and do the ICE examination. And then back here at Duke is where we do the ultimate study, and we had a pretty nice setup here. You can see I'm manipulating the ICE probe, and on one screen I can see the actual echo pictures from ICE. On the next screen we have the CARTO map of the heart as we move along, and then finally I have Fluoro here to help me guide where to position the ICE probe. So we were able to move through a series of successful animal studies in this manner. And I thought I'd just show a picture of what ICE pictures look like, because I don't think a lot of us look at this. And this, you get really high fidelity images, really very pretty pictures. And so here my probe is in the RV up top, and I'm looking across the interventricular septum. You can see very nicely the RV septum contracting towards us and the LV septum contracting away. So in this way we were able to obtain very nice RFE data from an ICE modality. And so I'm going to show you some sample results from our animal studies here. I know there's a lot going on, but we'll break it down piece by piece. The bottom left here is the ECG, which we're all familiar with. All of our acquisitions were gated to the animal's ECG. Above that is the absolute RFE displacement that occurred with each pulse. So we fire a pulse, and the tissue was displaced a certain amount, and we can measure that. And what you'll see is that there's a nice cyclic variation of tissue that doesn't displace much. This represents stiff tissue, versus tissue that displaces to a much greater degree, and this would be softer tissue. And you'll see that this correlates pretty well with diastole. The tissue gets soft as you'd expect, and systole, where the tissue stiffens up as it contracts. And we see this again in the color representation, where the red represents the greater displacements seen during diastole, and the blue is the stiffer tissue during systole. And I know it's hard to see on the screen, but this is actually the lateral wall of the LV that we were looking at. We also performed studies in dogs, and I just want to show this because the dogs were smaller and had less attenuation, and we could interrogate more of their myocardium, and so we could actually perform longer pulses, 4 sequence here, and get very nice reproducible data where we get soft tissue during diastole, stiffens during systole, and very nice reproducible data. And this is all transthoracic and non-invasive. We did have one pig where we were able to successfully identify infarct using our transthoracic probe. It was here in the LV apex. It was a very thin area, clearly akinetic. And what you'll see here is that instead of seeing a nice cyclic change of stiff to soft with colors in the red to stiff again, it's basically staying blue, which indicates that that tissue is stiff throughout the cardiac cycle, which would be consistent with infarct. That made us feel a little more reassured that we were accurately assessing the pathology in this animal. And then, although this isn't the focus of my talk and most of what I did want to just show what we can do by ice. It's really very, from what we do, very pretty data. So this is a 4-second acquisition, and you can just see how reproducible these results are. As soon as you get the onset of systole here with the QRS, the tissue stiffens up as it contracts, then it relaxes with diastole, you get more displacement, stiffens up, and very reproducible data over all of our animals. And this is a healthy septum here, and then you can contrast that with our infarct data where you don't see a lot of that red high displacement area. And in fact, if you just look at one bead, it appears that there's very minimal viable tissue, and this is actually on the RV side of the septum, suggesting that this is basically a primarily transmural infarct in the septum here that's been adequately assessed by ARFI. And this is just a representative sample of what we found by our ex vivo MRIs after we sacrificed the animals and removed the hearts. You can see clearly that there's areas of infarction here in kind of the distal septum and the lateral wall. And what you'll find interesting, of course, is that I told you they embolized the LAD. It looks like more than just the LAD got affected here, which we had realized over the course of the study, but it didn't matter too much. It actually gave us more targets to look at as far as infarct versus normal tissues. So as far as conclusions from our animal studies, I think it was very clear that ice is an excellent modality through which ARFI could be used. Of course, an obvious limitation is it's invasive, but it produced very highly reproducible and high-quality data. The transthoracic data was a little less reproducible. Early on, when the pigs were smaller, we were able to reproducibly show changes in systole and diastole and adequately interrogate different parts of the myocardium. As the pigs grew, and we had thicker layers of bacon form in between the probe and the heart, you'd go from kind of 3 centimeters to 6 centimeters before you get to the heart. And so at that point, between attenuation and clutter, the efficacy of our methods were limited. But I think this made us feel comfortable that at least before we made the jump to humans, our algorithms were sound and that we could actually accurately track ARFI displacements in the setting of intrinsic cardiac motion. So from this, we moved to a human clinical trial. Before we did that, we had to extensively test all of our sequences to make sure that probe face didn't get too hot, to make sure that the areas we were targeting with these higher intensity ultrasound pulses didn't exceed FDA limits of intensity exposure, and to make sure that the overall tissue heating in that area didn't go higher than 6 degrees Celsius, which is the FDA limit. One thing I didn't touch on, I won't spend too much time on other than to say it's a limitation for us, is a mechanical index. And again, without going into too much physics, this is a metric that limits the amount of push or power we can put into our ARFI pulses to cause displacement. And certainly in animals, it proved to be a limitation that if we stayed at the FDA limit of 1.9, we could only interrogate myocardium up to 5 centimeters or so. And so we already knew that this was going to be a potential limitation going into the human studies. The overall goal of our initial study was to be a proof of concept. This has never been done in humans, never been done in moving targets like the heart from a transthoracic standpoint, so we just wanted to show that this was a feasible concept. Our hypotheses were that, as we saw in animals, that diastolic displacements would be greater than systolic. We also created a separate part of the trial where we increased the mechanical index from the FDA limits of 1.9 to 3.0. We'd already done this in the animals and got IRB approval to try this in humans, given that there's been extensive literature in animals suggesting that this would be safe. Because we thought that if we could show that these increased power levels are necessary for successful interrogation of myocardium, that this may promote changes in the future in ultrasound. We did want to make sure that there were no ectopic beats at these higher MI limits. And we also created this metric of a diastolic to systolic displacement ratio. We were hoping that this might be an independent measure of tissue stiffness that we could use between different people and across MIs. So the enrollment criteria for our study were basically patients without any known cardiac disease, and they had to have at least one prior clinical echo, which removed any possibility of any structural heart disease or abnormal diastolic filling. It turned out most of our subjects were very young and healthy subjects who ended up enrolling in other studies, so they really did have very healthy hearts. We again used this Verisonics research scanner as opposed to a clinical scanner for the reasons I already touched on. As far as image acquisition, standard left lateral decubitus views, and I'd get 2-chamber and 4-chamber apical views and target 5 segments in the heart. All acquisitions were gated to the patient's ECG, and we recorded the ECG throughout the image acquisition process, again, to make sure that we were not inducing any PVCs with any of these pulses. The actual RF excitations as well, I won't go into too much detail, but they're less than half a millisecond using a 2 megahertz probe at acquisitions at 25 hertz. And we did several measurements at each of the MI levels in each of the parts of the heart we were interrogating to make sure whether these were reproducible results. And the measurements were measured along the center line of the M mode. So here's some sample data I'll show you. This is from the LV apex and the 4-chamber apical view. And again, we'll start with the ECG here, which we're all familiar with. You go right above that, and you'll see this nice cyclic pattern where during systole, you see that there's a lot less displacement, again, suggesting that the tissue is stiffening with contraction. And then during diastole, it gets softer, and it's able to displace further with our ultrasound pulses. And again, you see that represented here in the color bar. So the next two slides will be kind of the crux of what I presented a couple of weeks ago at ACC. So basically, this represents the summation of all the data from the LV apex that we took from all our patients. On the y-axis, we have absolute diastolic displacements, and on the x-axis, we have absolute systolic displacements. The yellow diamonds represent acquisitions that were obtained at an MI of 1.9, and the red squares are those obtained at an MI of 3.0. And as you might expect, those with higher power, those at the MI of 3.0, had higher absolute displacements across the board as compared to those which were obtained at the lower power. If you look at the overall results, we had 56 total acquisitions at the LV apex we could look at. If you compare mean diastolic displacements to the mean systolic displacements, they were significantly different, which isn't surprising, but again, just made us feel better about the quality of our results. And this occurred at both the MI of 1.9 as well as the MI of 3.0. What was interesting is that the ratio between diastolic and systolic displacements was similar was not different across all patients. And we wonder whether this may represent kind of a unique metric we can use using this method. For example, if you consider an infarct, you wouldn't expect that during systole necessarily that'd be much different than during diastole, whereas in healthy tissue you can see clear differences. So this may be something that obviously would need to be reproduced in a larger population in the future, but something interesting to look at. Also, we did not identify any ectopic beats throughout any of our RF excitations. The conclusions, I've already touched on a lot of these, but it does seem that certainly at the LV apex, even at FDA limits, we are able to interrogate myocardium and get reliable RF displacements. The ratios we obtained were similar in both arms with the MI and across patients, suggesting that this may be a unique metric if this method becomes clinically applicable in the future. And also, very importantly, it's the first time to our knowledge that pulses with an MI of 3.0 have been used kind of clinically like this, and they didn't induce ectopic beats, and they may be a safe way to do ultrasound in the future. Now, I do need to talk about limitations, which there's a whole host of. I won't go through all of them, but I'll try to hit on the high points. When we initially designed the study, we didn't necessarily want this just to be a proof of concept. We actually wanted this to be more and actually show that we could identify pathologic tissue and differentiate that from normal. So we had a separate arm where we were trying to enroll patients with MRI documented transmural infarctions that ideally incorporated the LV apex. Now, as you can imagine, in a lot of those patients, there's a lot of comorbid conditions. They're older, they're bigger, they've got lung disease. So when we do the ultrasounds, there's a lot more clutter, there's a lot more tissue that attenuates our signal. So we had much less reliable RF signals in these patients. Also, we found over the course of this time that pushing much deeper than 4 centimeters was tough from a transthoracic approach. And obviously, in reality, if we can't push more than 4 centimeters, that's really going to limit the applicability of this method. And furthermore, in a lot of the views I was taking, if you're looking at the anterior wall, the inferior wall, the septum, you're parallel to your mode of interrogation of the myocardium. So the myocardium is actually swinging in and out of your area of analysis. And by echo, it's hard to get orthogonal all the time to where you want to assess. So these are all issues that we were struggling with throughout most of the clinical trial process, and certainly would be things that we need to improve upon in the future. As far as future directions for RF, I think the first big step is to implement this on a clinical scanner. The Verisonic scanner was nice from a research standpoint, from a data standpoint, but as far as actual image quality, there was a lot more clutter than we're used to, and the control we have over the actual pulses themselves is not, or over the actual image itself is not as robust as we have with clinical scanners. So I think that'd be the first step. I think TEE would be very useful to look at with ARFI. We can interrogate other structures that we can't get to by transthoracic methods. The left atrium would be a prime example. Our EP colleagues are already working with us on some ARFI projects, but I can imagine if we could assess left atrial stiffness and responses to ARFI displacements, that could be something of prime interest to our EP colleagues. It could have some bearing on who's more likely to develop AFib, who may be less likely to have good results with ablations, and on and on. And finally, I think another area of interest would be intraoperative or open chest cardiac ARFI. This is kind of removes the clutter issue, gets you direct access to the heart, and I think there's a lot of projects we could look at. You get real-time assessment with ARFI, so you don't have to wait and process. I mean, you fire your pulses and you can see what's happening immediately. So you could imagine that in a transplant recipient or transplant donor, there may be metrics that we can measure in the heart that we can't get to by traditional diastolic dysfunction or other methods that could help us choose good hearts. Or perhaps on pump or off pump. This could be a way to directly study what happens to the myocardium when we go on pump or off pump. And these are things we've talked to about with our anesthesia colleagues about. And I know I want to give Ash enough time, so I'll quickly run through these, but I need to give a lot of acknowledgments for my research here. First, I need to thank Eric Velasquez, who's developed this imaging pathway, funded it, and it's been a very unique and really productive opportunity for me. It's allowed me to bring my old engineering skills back into play and also obtain some clinical skills while being able to spend a lot of time on research. I do think that having a world-class ultrasound group is something that we need to make sure to take advantage of in the future. It's a unique opportunity that Duke has that I don't think most other institutions have. As we recall, the phased array came from Dr. Kissel and Olaf van Raam, and that collaboration, and I have no doubt that future innovations can occur with our BME colleagues in the future. I specifically have to thank Greg Trahey, my engineering research mentor, for being supportive throughout the entire process, also funding me through my 2 years. He's always been incredibly welcoming and open with any questions I have, and has always offered all the resources necessary to try to make our work as productive as possible. David Bradway, as I already mentioned, has been my partner in crime through these 2 years. Without him, my research could just not have happened. He did all the engineering side as far as sequence design, programming, getting the Verisonics up and running, so I owe all this work to him. Peter Hollander, I touched briefly on the ice work I did with him, but we spent a lot of time doing the ice work in the animals. I did separate projects with Brett Byram and Bicey Bill that I didn't have time to touch on today, but I need to thank them for that. Pat Wolf is another PI in the group who worked with us. Jason Coons helped with a lot of our animal studies. Chris Argis made sure that our IRBs were staying up to date and kosher. And Dr. Kislow has always been a huge help with developing our clinical protocols and making sure that we get things through the IRB. And also have to thank Han and Loie Van Asch for spending some late nights here doing our cardiac MRIs for us. And lastly, I need to thank everyone at Duke who's kind of influenced me over these last 11 years. I came here from college, from medical school, and never envisioned I would stay 11 years in Durham, North Carolina. But it happened. When I came here, I hated Duke basketball, but I'm now a diehard Duke fan. I've even been to a few Duke football games in the last couple of years, things I could never have imagined. But really, it's been an amazing time when I've developed as a person, as a cardiologist, as a scientist, and I really want to thank everyone. And specifically, I want to thank a few people, Neil Friedman, who allowed me to spend a year of my medical school training in his lab. And there, he really cultivated my love for cardiology, and then additionally kind of enforced in me the importance of scientific rigor and persistence in not just science, but getting whatever you need done in the right way. Also, I want to thank Michael Blazing, who's been my clinic preceptor for the last 3 years. It's been an honor to work with him. He's an amazing clinical mentor, and I can only hope that as I leave here and develop my own patient base, that they look at me with the respect and admiration that they look at him. And lastly, I of course need to thank my family. My wife Neela here, I convinced her to come down from Baltimore to Durham for her residency training, and she ended up loving Duke as well, so stayed for fellowship and ID. And it's been amazing and inspirational just to watch her develop as an academic doctor and all the successes she's had. We were blessed to have the birth of our daughter, Sonia, a week before the start of my research year, so it's been kind of an optimal time to have a child as well, and it's just all parents know how amazing it is to just watch your children grow. I need to thank my mom and dad for their support through this whole process, watching me get an engineering degree, a graduate engineering degree, and then going backwards and changing paths to go to medical school, residency training, and then choosing longer subspecialty training than some of my other friends are choosing. But finally they understand there's a light at the end of the tunnel, and I really have to thank them, because I couldn't have made it through this process without all of them. And I thank you for your interest, and thanks.